All right, I've got a series of 4 lectures in bacteriology, and we'll be talking about a few organisms. And the last one is a little overview of bioterrorism and what organisms and what potential organisms are there. So those 4 would be in bacteriology section, and then we'll start parasitology sections, where I would talk about different parasites. You'll find the way I have got my handout organized and the lecture as well. The way I look at it, you've got to know about the organism. Okay, what organism causing the disease? But even before that, when you are diagnosing a disease, you've got to know the symptoms. And together with the symptoms, a little bit of history is very important. Epidemiology of the organism is important because there are some rare ones, infections that either have been not eliminated, but reduced in their frequency because of the immunization, or those organisms are not endemic in the country. However, you've got to recognize from the symptoms what organism you're dealing with so that you can apply proper treatment. So the handout as well as the talks are organized, a little bit of biology of the organism, a little bit of epidemiology, then pathogenic mechanisms are very, very important both from the academic point of view, because you are going to be asked in boards and in the exams here as well, that we prepare for you for the boards. Of course, some of the treatments are dependent on pathogenic mechanisms of the organisms. So that's how. And the last, point that I try to address is the treatment, but don't pay too much attention to what is the antibiotic of choice, because what antibiotic of choice is today, it may not be when you are practicing medicine, because the newer generation of antibiotics are coming. So if you see a contradiction between what I tell you and by the time you come to pharmacology and they tell you, don't get too worried, because things change. That's one of the things that changes much more rapidly than certainly biology of the organism does not change that rapidly. Okay, so what we're going to talk in this hour is Bordetella and the species and Haemophilus. Among Bordetella, there are 3 organisms that are of clinical importance. By the way, did you do whooping cough PBL last year? Yes, you did. So you know something about Bordetella at least. I know that, I used to be a facilitator when I was, here permanently. But so yes, that is one of the interesting cases of pertussis. So pertussis is one of the organisms. Parapertussis is pertussis-like symptoms, but very mild disease, very, very much mild disease. And then the last organism, 3rd organism, is Bronchosepticus. That causes mild bronchitis. And I'm not going to give too much time to the last 2 organisms, Parapertussis and Bronchosepticus. What's the problem with? Okay. I'm going to start all these lectures with a little scenario. And because that's how you are going to see the cases when you come to. Here's a scenario, fictitious, made up, or it may not be so much made up, because I think I took some of the information from the POPS exercise, certainly the age of the patient. A 2-year-old male is presented to you with a 10-day history of persistent cough. The long cough spells are followed by a deep breath, and that's what is called whoop. That is whoop. The cough often leads to choking, vomiting, gasping, and cyanosis. His pulse rate is 190, means tachycardia. 100 to 160 is normal, and respiratory rate is 72 again. higher than normal. Breathing very fast because gasping for the air, at times because of the irritation of the bronchial, the pulmonary tissues. Chest X-ray is normal. WBC counts are 1600 per cubic centimeter. 16,000 per cubic millimeter it should be. Yes, cubic millimeters. Okay? With 70% of those lymphocytes, increased blood cell counts are lymphocytes. Okay? The normal WBC is the highest proportion is what? Neutrophils. Okay? Normally. Okay? There's a rule of the thumb that when you see, and that again was addressed probably in POPS exercise, PBLs, that if there is a bacterial infection, you normally get increase in neutrophil numbers. PMNs go up. Okay? And however, if this is one organism, and that rule does not apply, there is, instead of neutrophil increase, there is a lymphocytosis. Okay? And then what we have got to address, and we've got to find out, since you already know that it's a whooping cough, because that's the lecture we're in, what you've got to know is what organism is causing these symptoms. So when you study, that's the point of view you're going to study with. Okay? That will be your focus. What are the pathogenic mechanisms? That's an important thing for both your test and the boards, and also in terms of knowing the disease. Why is there predominance of or preponderance of lymphocytes? It's one of the toxins, perhaps. And what is the epidemiology and prophylaxis for the disease? So those are the points that we will address during this session. Okay, causative agent for that is Bordetella pertussis, B. pertussis. It's a gram-negative coccobacillus, very small, non-motile, gram-negative organism. And Dr. Fox already told you about gram-negative organisms. One of the characteristic of these organisms is presence of what? Lipopolysaccharide, endotoxin. And that's one of the pathogenic mechanisms for these organisms as well. And you probably have been given a lot of information on endotoxic shock, what lipopolysaccharide does. And we'll talk about a little bit more in this session. Okay? It requires a special mediated growth. That's important for you to know. As a matter of fact, it requires a special process to get the sample, and we'll put some emphasis on that. The media has got, you cannot use just regular normal blood agar, okay, because they are inhibitors of growth for the organism. So you use, instead you use a potato starch agar, or an agar that contains charcoal containing blood agar. And the particular generic name for that is Bordetella medium. The chocolate agar medium is also referred to as Bordetella medium. One sees, when one grows and looks at those organisms, one will find gram-negative coccobacilli. The colonies are small, transparent hemolytic colony, almost like a stars in the sky. You can see. And that's the typical characteristic textbook picture of Bordetella pertussis growing on blood agar containing charcoal. Okay? They are oxidase positive and urease negative. Okay? For the enzyme. And that's one of the tests that's applied to distinguish Bordetella pertussis from parapertussis or bronchosepticus. Parapertussis is oxidase negative, urease positive, and the bronchosepticus is positive for both enzymes. Okay, number of cases. What's the prevalence? There are 10 to 12,000 cases a year. Okay, if one looks at it, 2005, that's one of the sources, by the way, if you're ever interested in any of the diseases, their prevalence, MMWR is a magazine published weekly, morbidity and mortality report by CDC, and you can get a lot of current information on vaccines, immunization schedules, and epidemiology of different infections, particularly the diseases that are reportable or notifiable diseases. So in the U.S., there's about 8 to 10,000 or 10 to 12,000 cases, some years more than the others. Southeast, if you look at the neighboring countries, I usually look at Georgia, Tennessee, North Carolina, Florida, because those are the places you might be going for, your residency. And the incidence there is about 600 or so cases per year. And South Carolina itself, you get a reasonable number of cases per year, under 200. Okay? So in your clinical years, 2 years, if you're lucky, you might see a pertussis case in pediatrics. Dr. Stallworth will certainly ask you about them, about the disease or the organism. Pertussis is a disease mainly of children. Okay, if one looks at the epidemiology or a graph of it, one sees predominantly the disease in children below 5 years old. But it doesn't mean that the adults and grown-ups can't get it. Again, your PBL exercise underscored that fact, because the daughter or child was in that family got it from the father who was a physician. Okay? So, and in the adults, the disease may be milder, so it may not be diagnosed as pertussis. If one looks at the last few years, you can see that the below 1 year is sort of remaining constant. Okay, but there's an overall increase in the incidence, in the frequency of the disease, and that is primarily because the adults are getting more and more of the disease. The immunization schedule, if you remember, DPT is given only up to a certain age, and beyond that there are no usual boosters. And since the disease is not in the environment, we don't get the booster immunization by subclinical infections either. So the incidence in the adults is slightly increasing. As a matter of fact, at one stage, there was some worry that the vaccine we're using is not effective against the organism because the organism has somehow changed. That turns out not to be true because there have been studies conducted on that. The organism is still there, but it's probably because that there is no spontaneous natural immunization from subclinical infections, and the adults are getting infected. The symptoms of the disease can be divided into 3 stages. A catarrhal stage, which is about 7 to 10 days after exposure to the organism, depending on the bolus of infection. The severity and the incubation period will depend on that. And then there is incubation period is there. Yeah, catarrhal stage that lasts 1 to 2 weeks. And then there is a paroxysmal stage. Paroxysm refers to the sort of episodes of persistent cough without stopping. And it may go something like, you start this mild cough, and then it continues. Okay? And that's a typical giveaway sign for it. The reason I can do it because I remember in my teens having had pertussis. Okay, whooping cough. So it comes handy now to make a point. Okay, all of you have heard probably the CD, the sound bite that was given with that PBL exercise, although it was very, very sort of low-key voice because of being a child or a small girl, it was, I think. That is followed by, and during this period, since there's a lot of mucus being produced and there's already difficulty in breathing, so it may lead to vomiting, cyanosis, and sometimes it can be fatal. Okay, if one persists through this stage, there is a convalescent stage where the paroxysms are sort of waning, becoming less frequent. However, because the respiratory tract is damaged, the ciliary bodies, the cilia that are responsible for the elevation of the internalized particles, they are compromised. The tissue is damaged, therefore the barrier is not there. There may be infections with other secondary organisms. So that can be one of the complications. It may lead to seizures or encephalopathy. So those are the symptoms of whooping cough. Virulence factor, there are several. Most important among them is pertussis toxin, which is also referred to as pertussogen. Then there is adenylate cyclase, and we'll talk about each of them individually in a minute. I'm just listing them first. Tracheal toxin is another thing. Dermonecrotic toxin is another toxin. Filamentous hemagglutinin is another molecule that is a pathogenic factor. And lastly, the organism being a gram-negative one, there is lipopolysaccharide. What do these toxins do? We'll talk about them individually. Pertussis toxin is an AB toxin. If you remember Dr. Fox, he mentioned AB toxin, where A stands for active moiety and B for binding. These toxins, unless they bind to cell membrane, they can't exert their effect. So binding unit binds to the cell membrane, and the active unit is internalized into the cell, and that's where they change the metabolism of the cell and cause their effects that way. It increases the toxin increases sensitivity to histamine as well as LPS. So if you happen to be allergic or something and you have got histamine being released, the pertussis toxin will make you more sensitive to it. It also increases sensitivity to LPS, and therefore, if one is likely to get into shock or cardiac problems, low blood pressure, even smaller doses of LPS will induce that effect, as opposed to in non-infected individuals who do not have pertussis toxin exposure. Okay, there's an increase in IgE levels, so allergy symptoms will get worse. T cell lymphocytosis is a very common characteristic feature, which I mentioned before. It impairs phagocyte functions, both phagos internalization and intracellular killing of monocytes and neutrophils. It also reduces their response to chemotactic agents, chemotaxis. So you are going to have all sorts of impairment of phagocytic cells. ADP ribosylase, a protein that is involved in the control of adenylate cyclase activation. Okay? And consequence of that is increased cyclic AMP in the cell, accumulation of cyclic AMP, and that in turn results in increased excretion of liquid, and that's why mucus secretion is increased in infected individuals. And if one looks at the mechanism, not mechanism, structure, here is the structure. It consists of 5 different chains. 4 of them are involved in attachment to the cell surface, and the active unit, subunit 1, is internalized, and it interferes with adenylate cyclase control. And here is a little picture from one of the books, and normally what one has is a good balance between active and inactive adenylate cyclase. Okay, and it's controlled by there's a positive signal, the stimulatory signal, and there is an inhibitory signal. Okay, and what pertussis toxin does is ADP ribosylates GI-GDP, and it cannot go through the cycle, and therefore the negative control of adenylate cyclase is interrupted. And there is, as a result, there will be an increase in, there will be GI-GDP, and there will be an increase in cyclic AMP because adenylate cyclase balance has tilted towards active form. Okay, so that's how it works. As opposed to that, you have already, Dr. Fox has already told you also that collar toxin can do the same thing, but there the site of action is slightly different. The site of the action here is the ADP ribosylation of the stimulatory complex. Yes? I'm sorry? The green is just, inactive, Red is the active, yes. And that's why the arrow here is thicker as well. Okay? Normally there's a good balance between the active and non-active. Okay, interchange. All right, so that's the mechanism, and that's how it differs from collar toxin. Net effect is the same, increase in cyclic AMP and increase in secretions in the case of cholera, diarrhea, watery diarrhea, and in the case of pertussis, increased mucus secretion. Okay. Adenylate cyclase, it affects the same thing. It is a temporary effect, but it acts via by combining with calmodulin in the cell, inside the cell. And that complex catalyzes ATP to cyclic AMP conversion. And here is the cartoon of that. Adenylate cyclase toxin binds to the surface membrane. It's internalized. There it will bind to calmodulin, and that complex will increase cyclic AMP in the cell. Okay? And the effect would be, as I said, same as the pertussis toxin, meaning that it will increase secretions, water secretions. Okay, tracheal toxin. As the name implies, it damages tracheal cells. In chemical nature, it is like peptidoglycan. As a matter of fact, some recent observations suggest that it is a monomeric form of peptidoglycan. It binds to the tracheal cilia, ciliary epithelial cells, and causes their damage. Inhibits ciliary movement, and it kills ciliary epithelial cells. There should not be 2 ciliaries. Ignore the second one. Okay? And that is the damage to tracheal ciliary cells is the reason for the continuous irritation and the pertussis. By the way, pertussis means, means high level or uncontrolled, excessive, and tussis means coughing. So pertussis means continuous, uncontrolled, increased coughing. Yes?
Maybe a really dumb question, but can you not cough if you have stuff?
Well, it is not, well, if I remember what it was, no. It's the same as asthma. That whenever there's irritation to Coughing, what is the coughing? Coughing is nature's way of trying to get rid of whatever is causing irritation in the respiratory tract. Okay? So whenever there's slightest irritation, you are going to cough, whether you want it or not. You can just try to control it, but then it's not controllable. Ask any asthmatics. Those have got those people who have got asthmatic.
Would that also cause
I don't know. Probably it's recompensated. Okay? Probably it's compensated by synthesis. Okay? Any other questions? No, because, cough is very difficult to control, especially when it is due to some irritation that is continuously there. Pertussis dermatoxin is a strong vasoconstrictor and therefore ischemia in the tissue, and that ischemia can damage the tissue cells. Synergizes with tracheal toxin to cause tracheal necrosis. So between tracheal toxin and dermatoxin, necrotic toxin, they both damage the ciliary epithelial cells. Filamentous agglutinin, that just as the name implies, it agglutinates or binds with the filaments, meaning ciliary bodies, cilia, and that is the actually molecule that helps the organism acquire a foothold in the bronchial tissue. Okay? One inhales a few organisms, they bind to the ciliary cilia, and they multiply there. Okay, here is a cartoon depicting cross-linking of cilia, and once you have cross-linking, they're not going to move freely, and they cannot get rid of the organism. Okay, lipopolysaccharide, I don't have to say much because you already know about what the lipopolysaccharide can do. Just briefly talking about it activates inflammatory cytokines that cause general inflammation, activates complement, and activation of complement will lead to some more inflammatory cell recruitment and inflammatory processes. It will produce anaphylatoxin that is going to lead to contraction of bronchial passages. Large quantities will, of course, cause shock because of reducing the blood pressure, the vasodilation, and it can lead to cardiac arrest. So septicemic shock, septic shock is not uncommon to lead to these things. So those were the pathogenic mechanisms by which the organism causes the symptoms. The diagnosis is based on symptoms. And once you hear that whoop, you cannot go wrong. The confirmatory test would be culturing the organism on Bordeaux-Gangu potato starch or potato glycerol agar. Okay? The treatment, erythromycin, is the treatment of choice, at least at the moment. Yes? No, I think the Bordeaux-Gangu medium is the potato starch. I may have misspoken, but the other one is blood agar with charcoal. Okay?
Is this called charcoal?
Charcoal blood agar. Yeah, charcoal blood agar. Charcoal blood agar, and then Bordeaux-Gangu is that. I wouldn't worry about the constituents of the medium. Just remember there are two media that it can be grown on, because other regular media would not support the growth. Okay, that's the important. If you see Bordeaux-Gangu and an organism grown on it and comes from individuals with that those symptoms, then it is Bordetella pertussis. Okay, since it is very susceptible to being inactivated by contents of cotton swab, one does not use cotton swab. If one has to use swab, it will be nylon, synthetic fiber swab, or it is the sample is collected by nasopharyngeal washing. And the vaccine, of course, is very effective. And that's the reason, if you remember, when I talked about vaccines and immunization, I showed you how dramatically different diseases have gone down, and pertussis is one of them. And I also told you that there have been incidents of either deliberately ignoring immunization, which was done in a small community in England and in Japan for a certain period, and during that period, just after that, following that abandonment of vaccination, there was a huge increase in pertussis cases and many, many, many mortalities from that. So we are very, very lucky that there is a vaccine, and the cellular vaccine, whole cell vaccine, was toxic or was creating a lot of problems, but the acellular pertussis vaccine now that is used is much more side effect free. And the vaccine actually contains the filamentous agglutinin and pertussis. Those are the two elements of the vaccine. Okay, so that was the pertussis. I'll be happy to answer any questions if you have. Okay, all right, I'll spend the next 15-20 minutes on this other disease. 2-year-old male presented to you with a 10-day history of persistent. Oh, this is the same. Just recap. Okay. We already know what the organism is, what the physiologic characteristics of the organisms are, what the pathogenic mechanisms are, and why there is a preponderance of lymphocytes, because pertussis is the one that causes the lymphocytosis. Okay, so the next case is a 5-year-old girl is presented to you with a severe headache, emesis, throwing up, fever, and a stiff neck. Huh? Okay. Okay, she had a 2-day-old history of mild upper respiratory system. Okay, only 2 days. So that's an important fact, or important point to remember, because the disease progresses very, very quickly. CSF examination revealed increased WBC, and most of them are PMNs. So there is a sign of meningitis. Okay, right away, within 2 days. The 100 to, also it has 100 to, or 1,000 milligrams per deciliter of protein. Normal values are very, very much lower. The glucose is decreased from normal values. Those are all signs of meningitis. And when Dr. Bryan talks to you, he will give more time to meningitis and CNS infections. Okay, and you've got to ask for yourself a question: what's the clinical diagnosis, and what is the organism that might be causing these symptoms and leading to these changes in the CSF profile? What antigen in the CSF will be confirmatory for the diagnosis? That's an important point. What is the component that you will find in the CSF that will confirm your diagnosis of whatever you are thinking? What are the virulent factors of the organism? That will be persistent continuously for all organisms that we talk about. That will be an important question to ask. And what is the epidemiology and prophylaxis for the disease? So the same questions as we asked for when we were talking about pertussis. The disease is caused by Haemophilus, namely Haemophilus influenzae, serotype B. HIB is the abbreviation often used. There are related organisms that may cause other symptoms, the parainfluenzae and Ducreae is another organism which causes sexually transmitted disease. And we'll talk about. And the last one, Haemophilus influenzae aegyptius, or now you will see often just Haemophilus aegyptius, the name of the organism. That we'll talk about as well. That is a related Haemophilus organism, but does not cause all those symptoms that we talked about in that girl. It is a sort of purpuric fever. Okay, conjunctivitis it causes. Okay, number of cases in the U.S., very, very rare. It used to be a major cause of meningitis and encephalitis. Major cause of death among children, among infants. But this is, yes, for the whole nation. No. This is Haemophilus. Haemophilus influenzae, bacterial infection. Don't confuse it with, I'm glad you said that. Okay, don't confuse it with influenza, which is a viral disease, and Dr. Hunt will talk about it. No, there are many, many, many more cases of influenza. No, this is not the organism that is in your vaccine for influenza. By the way, the student center is giving a vaccine? Or not yet? Oh, okay. Okay. So the cases have reduced, and you will see the comparative epidemiology in a minute. Southeast, there's only one case. Okay? That was this year. And South Carolina, none. So if you are lucky, you're not going to have to treat anybody for Haemophilus B, HIV. And the reason for that is really vaccination. Vaccine. That's the reason. It's a disease, when it was prevalent, primarily of children below 1 year age. But since the development of vaccine, as you can see, the 90s, okay, it was way up there, and this is incidence per 1,000, I think it would be, or per million, I don't remember. But the point I'm making is that from a very high incidence, it has gone down tremendously in the recent years. Okay, there are other influenza Haemophilus organisms, but the most serious one, most infective or the most virulent one is Haemophilus B, HIB. And that B stands for actually types of sugar they have, okay, or serotype. There are others, A and other letters assigned to those. The Haemophilus B causes, as I told you, and or indicated, it causes meningitis, it causes epiglottitis. That's one of the symptoms is very characteristic of Haemophilus influenzae B. Epiglottitis. I did not have in that description, but as soon as you see those symptoms or an epiglottitis, think Haemophilus B. The bacteremia, of course, it is invasive organism. It will be caused by Haemophilus B. And the other symptoms that are indicated here are really, it is a second commonest cause of otitis media among children, non-B Haemophilus organism. Okay? Likewise, tracheobronchitis, non-typable organisms can cause, and pneumonia as well can be caused by non-typable. And I'm not going to talk too much about any other organisms among these. Haemophilus aegypti, conjunctivitis, and purpuric fever. It's also referred to as Brazilian purpuric fever. Okay? Haemophilus ducreyi, not very common, but not too long ago there were several cases of these in California. Okay? It's a sexually transmitted disease causes chancroid, which is lesion, ulceration, and lesion in the genital tract. Okay, Haemophilus influenza are all gram-negative bacilli. Okay, nothing particular about that they can grow very easily. Okay, but they require a supplement. They require supplementation of the medium with factor X. Factor X stands for unknown factor when it was non-known, but actually it is known now as hemin. And hemin comes from lysed blood. Okay? So hemin disc, if one puts hemin disc and one puts NAD disc, NAD is factor V, and factor V vitamin. Okay, that's how you can remember. Vitamin, factor V.
So these are not like factor 10 and 5?
No. Hemin and NAD. Okay? And the way so X, is hemin X. I remember, when I had to remember, exsanguination means letting blood out, okay? Or, that to me is a better way of remembering than unknown factor. Okay? Exsanguination, blood factor, hemin, and V is NAD or vitamin. And you can see a growth of organisms in between, a restricted growth in there. So Haemophilus influenzae B requires both hemin and NAD for its growth.
How does it growth of chocolate?
No, this is not chocolate. Chocolate agar would have lysed blood in it. This is a nutrient agar plate. Oh yeah, normally it will. Okay. It's a chocolate agar with factor. They include in the chocolate agar with hemin.
There's not actually chocolate in there.
No, there's no chocolate in there. Chocolate agar refers to, okay, sorry about that, nowhere you get any idea of what different media are. So those of you who have not had any microbiology would not know. What chocolate agar is, you take blood and lyse it, okay? Lyse the blood, or as a matter of fact, what they do is melt the base, agar base, nutrient agar base, and then while it is very hot, they put in whole blood. And that lyses and becomes lysed blood and slightly darker, okay, non-granular. As opposed to that, in blood agar, what they do is take the blood, melt the base agar, nutrient agar, let it cool, and then put in blood, okay, defibrinated blood. And that becomes blood agar, as opposed to chocolate agar.
You earlier said charcoal agar?
Charcoal agar is totally different. That is in the medium that you use for Bordetella pertussis. Charcoal is a very good absorbent of different molecules, okay? And that absorbs the inhibitors of Bordetella pertussis. So that is really charcoal, okay? So now you have got three CHs, okay? Chocolate, charcoal, and what was the other one? No, not the other one. And the blood agar is different from that. So what you have got to remember is that it requires factor X and factor V. Okay? Hemin and NAD. Okay, I'll take a couple of more minutes and let's just talk about symptoms, and then we'll finish off the rest of it on Monday. The runny nose, it starts off with the runny nose. Low-grade fever and headache. And headache becomes very quickly more and more severe. Okay? And within a couple of days, there will be onset of meningitis if it's not recognized and treated properly. So when the disease was very common, infection was very common, they usually advised mothers or the family to bring the child very quickly. The neonatologist will, or pediatrician would have that message there that if there is a severe headache, persistent cry, of course in the children they can't tell, Mom, I've got a headache. So persistent crying and, runny nose and fever, rush them to the physician because the disease progressed very, very quickly. Septicemia ensues very, very quickly. It can cause septic arthritis, conjunctivitis, cellulitis, and most importantly, characteristic feature being epiglottitis. And again, as it progresses, within those 2-3 days, it will cause meningitis, convulsion, and coma. Those are the very important symptoms. Airway obstruction because of epiglottitis. And suffocation. Secondary complications are very important because if the disease is not treated properly, it will leave persisting permanent damage as a hearing loss and mental retardation. Just to make the point, about 6-7 years ago, there was a student at USC, and I knew the family, that's why I know the case. What happened is that he came down with early symptoms, was not recognized as Haemophilus. He was treated, he survived, but he became permanently deaf. And he did have some, learning difficulties as well. So it is important to treat the disease, recognize the disease, and treat very, very quickly. Fortunately, it's not very common anymore. Why isn't it common? Because of the vaccine. Very, very effective vaccine. So I'm going to leave it there. Yes.